And we will now start with the panel speakers, and our moderator for this session is Dr. Nicole Rosendale, who is an assistant professor of neurology in the neurohospitalist division at the University of California, San Francisco. Dr. Rosendale was part of our planning committee, and she will now introduce the speakers and the panel for our session 1, evidence of disparities in access to care. Thank you.
Thank you so much for that generous introduction. And I'm so excited to be here and to be moderating this panel of experts and thought leaders, and just really excited for this afternoon. We're going to start off with Dr. Altaf Saadi, who is a general neurologist and neurohospitalist at Massachusetts General Hospital and assistant professor of neurology at Harvard Medical School. She's also the associate director of the MGH Asylum Clinic. Dr. Saadi.
Thanks so much, Nicole, and thanks for everyone for being here. I'm honored to be the speaker focusing on forcibly displaced populations. Next slide. I want to start with some definitions. So refugees and asylum seekers are a subset of the broader migrant population. They're fleeing persecution based on race, religion, nationality, membership of a particular social group like LGBTQ status, or political opinion. And asylum seekers have requested asylum, but they haven't had their case determined yet, whereas refugees have already gone through the process and they've had a positive outcome and they've been granted protection. What I want to emphasize here is that these are legal definitions and they're subject to the constraints and biases of the legal system. So just to give people a sense, the grant rate of asylum cases here in the US ranges from 0.8% to 93%, depending on which judge you're randomly assigned to. So in other words, someone can have incredible trauma exposure, but not have this label, not because of anything to do with their experience or how that in fact affects their health, but as a result of the legal structures we have. Next slide. And I want to begin with a framework how to think about these issues faced by this population and emphasize 2 points. One is that trauma doesn't end with migration. So this is the immigration intercept model that thinks about the continuum of immigrants' experiences. And if you look at intercept 2 to the second column, we list the negative social circumstances that people deal with after they've migrated. So people's problems don't disappear just because they've moved and haven't been granted protection in a new country. Second, we can't reduce immigrants' journeys to a simple pre and post migration story, right? There's also the journey itself that can confirm harm. The journeys can also include immigration detention that acts as a catalyst of worsening health. And this journey exposes people to cumulative trauma, not just across the life course or this migration continuum, but also within each aspect of the continuum itself. So in detention, someone can be subject to solitary confinement, sleep deprivation, and have difficulty accessing medical or psychiatric services. Next slide. In terms of barriers to access, I've divided it into internal or individual barriers and structural barriers, but want to acknowledge that these are very much interconnected. So for example, I may list fear of deportation as an individual barrier, but obviously that's embedded within laws and law enforcement actions. Next slide. So with that in mind, one barrier, which Dr. Crawford's talk did a really great job of delving into, is mental illness and associated stigma. There's a higher prevalence of psychiatric illness in this population, and that can act as a significant barrier to care, and shame and stigma that, in terms of just sharing psychological trauma and histories of abuse. Second, there's mistrust and perceived discrimination, and mistrust can occur at multiple levels. Just one point to emphasize here is that it's often very much deeply rooted in past experiences of trauma, which sometimes even involves healthcare professionals having turned a blind eye to abuses in their home countries. And then there's fear of discrimination based on what paperwork someone may or may not have. Related, there's fear of deportation. People conflate immigration law with healthcare system. People worried that there's information sharing across sectors. People may be worried about medical bills, and maybe if they can't pay them, that's going to lead to arrest or detention or deportation. And oftentimes that results in people not seeking healthcare unless it's an emergency. And then there's lack of awareness of this whole new system, right, and challenges in terms of navigating that. Next slide. In terms of structural barriers, really important to think about just resettlement stressors and prioritization, which means that in the face of all these resettlement challenges, people often don't prioritize their healthcare. So they're focusing instead on their immigration case, on securing shelter, food, employment, support for their families. There can be limited eligibility for services in addition to lack of availability and affordability. There's lack of cultural competence, particularly in providers and working with highly trauma-exposed populations. And then finally, a lack of adequate interpretation services. So we know from national studies that a minority of clinicians report regularly using professional interpreters, even despite federal legislation mandating that patients be provided medical interpreters. Next slide. And finally, I just want to make 2 points about neurologic and psychiatric disease in particular. So one, that they're mutually exacerbating. We know this to be true in the general population, but it's amplified in this population because there's a higher prevalence of mental illness. So for example, we know people who have mental illness and then they sustain head trauma, they're more likely to have persistent post-concussive symptoms in terms of thinking how they're mutually exacerbating. And then second, we have to recognize the bidirectional relationship between violence and neuropsychiatric illness. So violence can lead to neuropsychiatric illness. So for example, someone sustaining head injury from intimate partner violence. But there's also increased vulnerability to violence from having a neuropsychiatric illness. So someone with cognitive issues, for example, is more likely to be exploited or taken advantage of. So they're really keeping in mind this bidirectional relationship. Next slide. And so with that, I end with this quote that I love, which is just that the world is something that we make and we could just as easily make differently. And I look forward to our conversation together after everyone's presentations. And yeah, thanks again.
Thank you, Dr. Saadi. Such a powerful quote to end on, and I'm looking forward to our discussion later in just a few moments.